So, good morning, everyone. It's an honor indeed to be presiding as chair on this eminent oration. So, without further ado.
Few words about Matthew Roy.
Yes, so I'll.
So this is Professor B.C. Matthew Roy oration. As you all know, Matthew Roy is one of the best clinician, physician, endocrinologist, and he's born in a village near in Kodanjeri, 1982. He is not only an excellent student, but also excellent in sports, volleyball, basketball. In 1950, he got admission to MBBS in third batch of Trivandrum Medical College. He is passed MBBS with flying colors, and he did post-graduation in pathology, joined the second batch of MD Medicine in Trivandrum, and he was the first MD Medicine student of Trivandrum Medical College. And later he worked as a tutor, and then he worked under Dr. Pai, and from Pai onwards he was the best teacher, best orator, and he has various interests in different subjects like general medicine, cardiology, sports medicine, and he started sports medicine in Trivandrum Medical College, and then he was the first secretary of Association of Physicians of Cardiology Kerala chapter, and he was the past president secretary of API Kerala chapter, and he is honoring API. We have in the name of Matthew Roy, there is an oration, and later he was the professor of endocrinology, and after his clinics, he was coming from the Madurai Medical College, and later after seeing a patient, he had sudden collapse and he had a massive cardiac arrest, and he was one of the best teachers, clinician, and best orator of Trivandrum Medical College. And in his name, Matthew Roy, we are having this oration, and over to our chairperson.
And we have Dr. Pratap Jethwani. So my honor to be introducing him. He's going to speak to us about Somogyi Phenomenon, fact or fiction. Sir is a fellow of Diabetes India and RSSDI. He's ex-tutor, Leicester University and BMJ Learning. He's consultant diabetes specialist physician at Jethwani Hospital, Rajkot. National Executive Committee member of RSSDI 2022. And Chairman-elect for Gujarat chapter of RSSDI 2021-23, Honorary Secretary for Gujarat chapter of RSSDI, Organizing Secretary for RSSDI 2018 in Ahmedabad, and has been the very active past President for Association of Physicians of Rajkot from 2016 to 2018, and is currently the Honorary Secretary to Association of Physicians of Rajkot 2009 to 2011. So without further ado, over to you, sir, for your oration.
Thank you. Thank you, Dr. Ritu, Dr. Harish Kumar, for kind introduction and for making us aware of the work done by Dr. V.C. Matthew Roy in this part of country. So I'm grateful to Dr. Jyoti Dev and the entire team of JPEF for awarding me this V.C. Matthew Roy oration, and I will be speaking about Somogyi Phenomenon, fact or fiction. So we all know that the nocturnal hypoglycemia followed by morning hyperglycemia, which is because of the surge of counter-regulatory hormones like epinephrine, cortisol and growth hormone. This is being termed as Somogyi phenomenon. We all know this since our days of students, as medical students, as PG students, we know that. And that's why most of the physicians, whenever they see a patient who is having morning hyperglycemia, they are somewhat skeptical about intensifying therapy because of this concept of Somogyi effect, because nocturnal hypoglycemia may result in further aggravation of morning hyperglycemia. So how this effect was described, or first it was described by Michael Somogyi, and he is a Hungarian-born professor of biochemistry, and he was working in the Jewish hospital at St. Louis, Missouri. He developed variety of tests, the important being the cost-effective method for screening for diabetes and monitoring for glucose control, and that is by measuring urine sugar with the help of sodium carbonate and heat. And various papers, charts, colorimeters, they were developed based on this method. He also developed a method for determining serum and urine amylase. And if you remember, before few years, the value of amylase was coming in SU, that is Somogyi units. Now it is changed to international units, but this is Somogyi, this is the person who has developed Somogyi effect as well as Somogyi units for the measurement of urine and serum amylase. This is a beautiful paper which is published in Hormones in 2024, where they have tried to compare the timeline of Michael Somogyi's overall academic and professional career with the Somogyi phenomenon, which he described first in 1958. So this is the paper in which the title of the paper he gave was Exacerbation of Diabetes by Excess Insulin Action. So excess insulin resulting in hypoglycemia, that is resulting in release of counter-regulatory hormones, and that is resulting in hyperglycemia. So this is the title of his paper, and this was based on 3 patients who were admitted in the hospital who were having very difficult to control diabetes, because in those days only plain insulin was available. So this overall concept is based on very primitive data of plain insulin and urine sugar measurement. So what they have done, they have taken these 3 patients who were on very large doses of insulin, and that also only twice a day. This first patient, I am just highlighting one of the patients, he was on 30 units at morning and 30 units at night. And how they adjusted the dose, or they checked whether the patient is having good glucose control or not, they used to collect urine from breakfast till lunch, lunch till supper, supper till breakfast. And they used to measure the overall amount of urine in that collected, glucose in that collected urine for that period. So here if you see, this is urine sugar, breakfast to lunch, lunch to supper, supper to breakfast, and then that is a total for day. Same way, the total carbohydrate they are taking, protein, fat, and from that they were calculating what is the total glucose which is available, the amount of insulin given, the amount of insulin which is excreted, and then they were saying that 161 grams of carbohydrate or glucose was utilized by 60 units of insulin. So this was the way of treating diabetes in those days. Now, because of this 30 units, in between the urine sugars were going very low. And whenever the urine sugars were remaining very low, immediately following, there was a period of hyperglycemia which was resulting in lot of glucosuria, so the urine sugar will go up. So based on this observation, he came to conclusion that there are episodes of hypoglycemia which are followed by hyperglycemia. But this is based on not blood sugar estimation, this is purely based on corroborative evidence of urine sugar estimation. And what they have done what we are doing, rather than giving 2 doses of plain insulin, now we understand that plain insulin has got a maximum action half-life of 7 to 8 hours. So 2 doses will never be able to cover glucose in a proper manner. So what hyperglycemia was occurring, whether it was because of release of counter-regulatory hormones or it was because of lack of insulin action at that time, it is difficult to say, because now we know the physiology and other things. But way back in 1958, this was the concept he designed. And then he divided the insulin in 3 doses, small dose at afternoon, and even they have even gone further to give 4 doses of plain insulin. And they have shown that the sugars, they don't go down, and the sugars, they don't go down, so there is no hyperglycemia. So this is the way Somogyi designed this concept. These are 3 patients' data. This is urine sugar, daily urine sugar for 3 days period. In between is a low urine sugar, and this is followed by surge in urine sugar. So hypoglycemia followed by hyperglycemia. Same is happening in all 3 patients. And what was the summary? It was a very lengthy paper. It was around 22 pages paper. The summary, the first thing is the high tides consistently occur in the wake of hypoglycemic reactions, even after asymptomatic mild degree of hypoglycemia. So a clear-cut cause and effect relationship unfolds between hypoglycemia and the next upsurge of hyperglycemia. That means he has come to conclusion that excess insulin can lead to hypoglycemia, and that will result in subsequent hyperglycemia. So excess insulin action can cause hyperglycemia. That is what the title of his paper was. And Somogyi and few others, they have already shown that in laboratory studies and other studies that hypoglycemia results in an accelerated release of adrenal pituitary blood sugar raising hormones, and this contributes to hyperglycemia. That is what he corroborated from this data. And the last thing which he said, if you are seeing such patient and if you keep on increasing the insulin dose, then this will further aggravate this cycle. There will be more hypoglycemia, there will be more hyperglycemia. So this cascade will continue, and this he termed as diabetic syndrome. Extreme fluctuations of glycosuria with mounting peaks and ketonuria, at the same time recurrent hypoglycemic reactions, they increase in severity. So this was the primitive data based on which the Somogyi effect, they came into picture, and everybody was fascinated and everybody started following this as a physiological phenomena, as an important phenomena for diabetes management in their day-to-day practice. In 1980s, lot of people, they criticized this Somogyi effect. This is the first study which was carried out in 15 patients who had 17 episodes of asymptomatic nocturnal hypoglycemia between 11 p.m. and 3 p.m. The blood glucose was less than 2 millimole per liter. And here, the fasting glucose concentrations at 7 a.m. were more than 7 millimole per liter in only 6 of individuals. So out of 17, only 6 were having morning hyperglycemia. And here, they have also tried to find out what happens to the counter-regulatory hormones and what happens to the free insulin concentrations. And surprisingly, there was no elevation of growth hormone, cortisol, or glucagon as compared to the people who were having no recovery of glucose. At the same time, if you see this graph, as the free insulin goes down, the plasma glucose goes up. So this is clearly shows that the morning hyperglycemia was not because of surge of counter-regulatory hormones, it was only because of lack of insulin at that point of time. So nocturnal hypoglycemia does not result in release of counter-regulatory hormones and subsequent morning hyperglycemia. Lot of papers are there related to counter-regulatory hormone response to hypoglycemia. And most of these papers, this is one of the paper by Cryer, and he has done lot of work on this in normal individuals. What happens to insulin-induced hypoglycemia? Both animal studies and human studies. And they have clearly shown that counter-regulatory hormones, the most important is glucagon, and that works only in the presence of adrenergic hormones, that is epinephrine. If they are not there, then glucagon will also not work. So adrenergic hormones and glucagon, these two are responsible somewhat for bringing glucose to the normal level. But they do not result in hyperglycemia, which was suggested by Michael Somogyi. So this is again refuting the hypothesis of Somogyi. Two things. One, there is not sufficient or strong increase of counter-regulatory hormones, and second, there is lack of insulin action which is contributing to morning hyperglycemia. This is a very beautiful paper which summarizes everything in 1984, depending on the evidence which was available at that time, which was published as a special communication in Archives of Internal Medicine, that under most circumstances, unless food is taken to relieve symptoms, nocturnal hypoglycemia does not lead to rapid and marked increase in the blood glucose level, despite the release of counter-regulatory hormones. Hypoglycemia in a fasting insulin-treated patients can persist for hours, and the eventual increase in the blood glucose concentration to hyperglycemia levels, they are mostly related to fall in insulin action rather than release of counter-regulatory hormones. This is another data. This came after the advent of glucometers. This is data from inpatients at Washington University Hospital, where the indoor patients, they have measured their blood sugars at various points of time, 7, 11, 16, 21 and 3 a.m. And then they have tried to identify 11, 12 profiles in 11 patients, those who were having nocturnal hypoglycemia before. This is before, day before nocturnal hypoglycemia, and this is day after nocturnal hypoglycemia. The morning blood glucose is not higher. So they have clearly shown that those people who are having nocturnal hypoglycemia, they do not present with higher morning blood glucose second day. And this is because now they were treating them in a better manner with better insulin molecules which were available at that time. This is the only paper which was published in NEJM which gives some credit to Somogyi phenomenon. This is a good paper where they have given patients the continuous subcutaneous insulin infusion, and they have maintained their sugars in a normal range. Then they have checked their blood sugars at various levels, and during night they have given extra dose of insulin by infusion. And in one group they have produced hypoglycemia, and in the second group they have maintained the blood sugar in the normal range by simultaneous infusion of glucose. And they have tried to see the patients who are being developed biochemical hypoglycemia, what happens to them. So they clearly shown that there was an increase in glucagon, epinephrine, growth hormone, cortisol, everything there was a surge, but this was for a short period, and this probably translated into a higher fasting glucose in people who were exposed to this nocturnal hypoglycemia. But this is iatrogenic. I think this will not happen in routine life in humans who are now on current basal insulin analogs or on other drugs. So this is very much controversial still whether Somogyi phenomenon is there or not. And they clearly concluded that there is a clinically important deterioration in glycemic control in patients who are receiving intensive insulin therapy, and therefore unexplained morning hyperglycemia, you have to keep in mind this can be Somogyi phenomenon. So, does the Somogyi effect truly exist? Do we worry about it so much in routine clinical practice when we are treating our patients with intensive insulin therapy? Do we worry about this thing? Does the nocturnal hypoglycemia result in morning hyperglycemia? I think we have come a long way from the plain insulins to the human insulins, to now insulin analogs, and we are towards the way of once weekly insulin therapy also. And as far as monitoring is concerned, we have come a long way. Now we have got real-time CGM. We have continuous insulin pumps which are combined with CGM. There is automated insulin delivery, hybrid closed loop system. So a lot of technological advancements have taken place in insulin therapy and monitoring. And this CGM data can definitely help us in understanding whether Somogyi phenomenon is there or not. So I will touch upon few studies which were done in last decade related to Somogyi phenomenon with the use of retrospective analysis of continuous glucose monitoring. So this is the first data that Somogyi phenomenon revisited using CGM in daily life. And here they have divided patients who were having nocturnal morning hyperglycemia, and they have correlated it with the morning blood glucose was correlated with the nocturnal hypoglycemia. These dark bars are nocturnal hypoglycemia and light bars are those who are not having nocturnal hypoglycemia, and this is the morning blood glucose. If you see the morning blood glucose above 7, ideally those who are having nocturnal hypoglycemia, they should have a higher blood glucose. So most of them should be here. But instead, those who are having nocturnal hypoglycemia, most of them, they are having fasting plasma glucose that is less than 5. It is here. So less than 2, almost 80%, they are having nocturnal hypoglycemia. Less than 3, almost 60% they are having nocturnal hypoglycemia. So the risk of nocturnal hypoglycemia increases progressively as the morning glucose values that decrease. And this is based on CGM data in 262 patients with type 1 diabetes in routine life. This is not hospitalized patients. This is retrospective analysis of CGM data from 262 patients with type 1 diabetes. So this is first clear-cut proof that nocturnal hypoglycemia does not translate into morning hyperglycemia. This is another paper by Professor Pratik Chaudhary from Leicester University, where I was an honorary tutor. that do high fasting glucose levels suggest nocturnal hypoglycemia. And here they have compared the lowest overnight sensor glucose, and this is the fasting capillary glucose. So if you see, as the sensor glucose at night, it goes down, the same way the fasting plasma glucose also goes down. It should be like, here it should be high, it should be like this if there is Somogyi phenomenon. But instead it is like this. So this means if there is a low sugar at night, the morning sugar will be low. If morning sugar is less than 90, there are more chances that the patient is having nocturnal hypoglycemia. And the same they have shown here, that lowest sensor glucose, if it is less than 3.5 millimole per liter during night, then the fasting capillary glucose is less than 5 millimole per liter in 16 of these patients. So they suggested that less than 5 millimole, that means less than 100 fasting patient on intensive insulin therapy, you should think of nocturnal hypoglycemia rather than fasting being more than 150 or 160. This is from type 2 diabetes, where they have again tried to find out what is the impact of nocturnal hypoglycemia and how can we predict nocturnal hypoglycemia based on fasting glucose and post-breakfast glucose values. And here if you see, the dark line is the nocturnal hypoglycemia patients, and the broken line is the patients who were not having nocturnal hypoglycemia. Those who were having nocturnal hypoglycemia, their morning glucose were less as compared to those who were having normal glucose during night, but post-breakfast rise was evident. So another clue, low fasting glucose and rapid increment in glucose after breakfast. These are the two features which can give you a hint that the patient might be having nocturnal hypoglycemia. This is data from type 2 diabetes. This is another data which is related to insulin degludec, and there also they have tried to find out, can we predict the onset of nocturnal hypoglycemia in patients with type 1 diabetes? This is corroborative evidence. Here again, the patients who were on insulin degludec, type 1 diabetic patients, if bedtime glucose is less than 90 and fasting glucose is less than 69, then 80% probability that the patient is having asymptomatic nocturnal hypoglycemia, and you should revise the insulin schedule. So it is not reverse. High morning glucose, you reduce the dose of basal insulin. No. Low morning glucose, low bedtime glucose, you reduce the dose of basal insulin. This is very large data from 2,600 patients with type 2 diabetes, retrospective analysis, where they have also tried to find out nocturnal hypoglycemia and its association with morning hyperglycemia, that Somogyi phenomenon. And they have clearly shown that morning fasting glucose was observed lower after nights with nocturnal hypoglycemia compared with nights without hypoglycemia. Fasting glucose below 3.9 in the morning, 100% risk of nocturnal hypoglycemia, and over 9.6 in the morning. If it is above 170, then it rules out nocturnal hypoglycemia. So low glucose predicts, gives you a hint. High glucose says there is no risk of nocturnal hypoglycemia. So all the CGM data, what they say, fasting glucose levels, if there is a nocturnal hypoglycemia in the night, fasting glucose will be low, and the more severe the hypoglycemia, the more lower the fasting plasma glucose will be. There is also evidence, because the feline diabetes is also like human diabetes, and it is also treated same way. Insulin glargine is also used in cats for control of diabetes, and this is one paper where they have clearly shown that the biochemical hypoglycemia does not result in rebound hypoglycemia, and therefore the cats who are on basal insulin, glargine, you need to increase the dose of glargine to control hyperglycemia. Don't worry about biochemical or nocturnal hypoglycemia. So I think I have clearly shown you the evidence based on CGM that Somogyi phenomenon truly is very, very, very rare. Generally, nocturnal hypoglycemia, the morning glucose will be low, the bedtime glucose will be low. If the morning glucose is above 170, 180, it rules out the presence of nocturnal hypoglycemia in current era, where we are using more and more long-acting insulin analogs and not the human insulin or NPH insulin. This is another data, the EPICHA study, which is done retrospective analysis of CGM from Belgium, type 1 children and adolescents, and they've come with another terminology. That terminology is post-hypoglycemic hyperglycemia. And this can occur because of overcorrection of hypoglycemia, or it can occur because of lack of insulin action. And they've also clearly shown that it is not related to the controversial Somogyi effect. That means hyperglycemia following hypoglycemia, it can be either because of overcorrection or it can be because of lack of insulin action. Counter-regulatory hormones surge contributing to hyperglycemia following hypoglycemia is quite rare. These are few examples of my own patient CGM. This is type 1 diabetic patient. Overnight sugar, if you see here, they are low, but the fasting glucose, if you see, it is again in the same range. It is below 3.9 or 4. The same patient, again, the dose was revised and everything was normal. This is another patient, type 1 diabetic, having hypoglycemia early morning because of long-acting glargine. The 2 days, the dose was revised. There is no surge following hypoglycemia. That is what I just want to convey. And this is the third and last patient where you see there is a nocturnal hypoglycemia and immediately there is a rise. So is this Somogyi phenomenon? No. Here the patient has taken a snack, large snack at night because of symptomatic hypoglycemia. And this snack has contributed to the rise in blood glucose, and morning insulin dose he reduced because of the fear of hypoglycemia, and that's why there was further surge. So this is not Somogyi phenomenon. This is because of overcorrection of nocturnal hypoglycemia, the morning hyperglycemia which is occurring. He has modified his dose, taken bedtime snack and modified insulin dose, and the second day it is normal. So to conclude, I will say, whenever there is morning hyperglycemia, think of three things. First is dawn phenomenon. The second most important thing is under-basalization, because Somogyi effect is very rare, and 3 a.m. blood glucose can give you a very good idea about what is happening to the blood sugars, or CGM can give you a very good idea. So if 3 a.m. glucose is low and morning glucose is high, then it is Somogyi. If 3 a.m. glucose is normal and morning glucose is very high, then it is generally dawn phenomenon. If 3 a.m. glucose is high and morning glucose is also high or very high, then it is because of lack of insulin action or lack of proper basal insulin intensification. This is a beautiful article based on which this topic was selected. This is by Professor Pratik Chaudhary and Simon Heller, published on the net. The Somogyi effect, fact or fiction. It is very good. It gives all idea about Somogyi effect. And they have concluded, this is the take-home message. Recognize that low fasting glucose levels, they are associated with nocturnal hypoglycemia. Many studies, they suggest an upper limit of target fasting plasma glucose. Whenever we are giving patients basal insulin, we talk about fasting plasma glucose. The upper limit, above 130, you increase dose by 2 units. Also talk about the lower limit, and that lower limit need to be increased to 100 milligram, not 90 milligram, because when it goes below 100, there is a definite risk of nocturnal hypoglycemia, particularly with first generation basal insulin analogs. A 3 a.m. glucose test or CGM can help you in determine the cause of morning hypoglycemia. Somogyi effect is very rare. Asymptomatic nocturnal hypoglycemic episodes, they are unlikely to produce a sufficiently strong and longer counter-regulatory response to raise blood glucose. Concern about Somogyi effect should not prevent, where appropriate, an increase in the evening dose of long-acting insulin in response to high fasting plasma glucose levels. So if fasting plasma is high, don't worry, increase the dose of insulin. Somogyi effect is very, very, very rare. With that, I again thank Dr. Jyoti Dev and the entire team of JPEF for awarding me this Dr. Vichy Matthew Roy oration, who is named after the pioneer in the field of medicine and endocrinology from this part of country. Thank you very much.
Thank you so much, sir, for that elaborate presentation. Any questions?
Sorry to interrupt, as we don't have much time, we are moving
Okay.
on to the next session.
Okay, sure. Thank you so much, sir.